as well. So you can earn 1 CPD point towards your RECP, my online RECP curriculum. Over to you, Julie.
Thank you, Rahul, and welcome everyone. I have the pleasure of presenting Georg Schmolzer, who many of you know already. He is the #1 researcher. I have to say that Georg, in newborn resuscitation, if you just look up Expertscape, there is Georg. So he is everywhere in the world of resuscitation. He's actually in Delhi now. So if anyone's in India, he is in your time zone. But what Georg is going to talk to us about today is how we can improve our delivery room care of the critically ill infant with many, many devices. So Georg has allowed us to record this session. Thank you. And I will check that nothing is too dodgy inside, and hopefully we can post it if it's all okay. So I'll shut up now, George, and over to you. Thank you so much for speaking.
Recording in progress.
Thanks, Julie, for inviting me. Hard to believe that I'm actually the #1 on that expert.
Yeah, you are. I'll show you the screenshot. Yeah, okay.
Because I think there's many others who have done much more than myself, but yeah, it's what it is. So thanks for inviting me today to speak. And I think the topic was quite large to just talk about how to help critical ill newborns at birth. So I decided in communication with Julie to focus on respiratory function monitoring, or how to do respiratory monitoring in the delivery room to help improve outcomes for our critical ill newborn babies. I have a few things I would like to disclose. There's certainly a lot of funding I've received to do some of the stuff I will present, as well as others. I'm also a member of ILCOR, the International Liaison Committee on Resuscitation, produces the neonatal resuscitation consensus of science and treatment recommendation statements. And I've also been, it's unpaid, but I'm on the advisory board of Monivent, who produces a respiratory function monitor, as well as KM Medical as a clinical consultant who has a ventilation device. Good. So certainly what we want to do when we have any of our newborn babies, and what the newborn baby does when it is born, it has to transition to independent life after birth. And this is a sequence which interacts between a respiratory and a cardiovascular transition, and this is some physiological event, and it only works if all of these events work in unison. If there's any issue with one of them, you certainly will struggle to get the baby transitioned over from the fetal to the neonatal transition. And if the respiratory transition, either the baby or if we need to help any of our premature babies, for example, we need to clear the air liquid out of the airways. We have to then achieve lung aeration. There needs to be an ongoing of continuous breathing, and gas extension needs to be facilitated. With that, in condition, in a sequence comes then the cardiovascular transition, where all the shunts will close, some faster, some slower, and then changes in interventricular output and the cardiovascular system, so that you get the transition afterlife. And how does it look like? So first of all, everything gets absorbed, and this is some videos or cartoons from Stuart Hooper, that you basically get all the fluid absorbed into your interstitial lung, and then you get gas exchange going. And only if you get gas exchange going, you will be able to see an increase in heart rate. And that's, I think, one of the most important aspects of providing respiratory support. It's not only just about how much volume you deliver or how much pressure you use. What you need to achieve is gas exchange, because if you don't achieve gas exchange, you will not see an increase in heart rate. And that's something which has been shown in many publications, many studies, mainly observational, but certainly that's a quite important factor. Now, we certainly know that, and that's the good thing when we have to health, that most of the newborn babies, they breathe spontaneously, and only around 10% of our premature babies need respiratory support. But certainly the lower your gestation goes, the more likely they will need help. And there certainly is also a lot of different breathing patterns where crying is the predominantly breathing pattern to help aerate the lung. And that's certainly something we will hear all the time, and something which is, I think, calming and maybe reduces some of the stress. Now, when we have a baby who doesn't breathe and need help breathing, then we have the same goals as the baby would have had on their own. We have to figure out ways to clear lung liquid. We have to figure out ways to help the baby establish functional residual capacity. That should lead up to facilitate gas exchange. We hope that we can stimulate breathing and ongoing breathing. We have to deliver an adequate tidal volume because we also need to minimize lung injury. This is something when you're spontaneously breathing, you don't have to worry about. But as we are providing positive pressure ventilation, we need to think about how we can minimize injury. Now, if you look at the current recommendation, and they haven't really changed over the last 10 or 15 years, only with a few minor adjustments, the consensus of science recommendations tell us that we should use a flow of 10 liters per minute. In premature babies, a peak inflating pressures of 20 to 25, with an initial PEEP around 5. If we need positive pressure ventilation, we should use a device which can provide PEEP, because PEEP has been shown to help remain the lungs inflated in between those positive pressure ventilation. Now, and this is just something from a paper by Jennifer Dawson, who basically showed that if you use a pressure, and what we do is we use a fixed pressure for most of our resuscitation approaches. If you use any fixed pressure, and it could be 20, it could be 25, 30, or 40, you can see that depending on mode of delivery, depending how much fluid is in the lung, depending on lung compliance and lung and resistance of the lung, that the tidal volume you deliver might vary quite widely. It could be quite low. It could be what we might consider adequate. It could also be extremely high. So there's certainly big variation, and that's an issue which we haven't really addressed in helping those premature babies at birth. Now, why is this something we should worry about if you, for example, deliver a too large tidal volume? Well, we can go back quite a while into the 90s, where studies in lambs shown that even if you just give a few inflations, and there were namely 6, with quite a large volume of 35 mils per kilo, that those lambs had quite a different reaction to surfactant after, and had lung injury. And people might have thought back then, well, no one is delivering 35 mils per kilo. But if you looked at the slide just before, you might remember that 20, 30, up to 40 mils per kilo was on that chart. So it's not something which doesn't happen, so it occurs. So certainly we should be worried about that. Further to that we need to worry more about pressure is other work back in rabbits, where they put casts around the rabbit chest to assess lung injury. And what they found is that the high tidal volume is much more problematic compared to the high pressure per se. So using a pressure of 30, but delivering a normal tidal volume or an adequate tidal volume, it's not as big of a problem compared to using the same pressure and delivering a high tidal volume. So certainly this is something we need to worry about. Now, one of the problems is what is an adequate tidal volume, and that's certainly something we have not really identified yet. Several studies used a tidal volume of 4 to 8 mils per kilo. Some units, when they used volume targeted ventilation on the ventilator, they might use 3 to 5 mils. Others use 4 to 6, and others might use up to 7 mils per kilo. So that's certainly quite variable, and there's not much evidence out there what would be an adequate tidal volume. This is one of those rare studies where they measured that in preterm babies, and what they found is that the total lung capacity at 10 hours of age with severe RDS is relatively small. It's only 19 mils per kilo with an FRC of 11 mils per kilo. So you can imagine that you might not have that much wiggle room when you ventilate a premature baby at the unit. But this is, again, at 10 hours of age, and there's not really any good studies out on what the optimal tidal volume might be in those premature babies, particularly as you go lower with the gestation age, because most of them don't breathe spontaneously, so that we could measure it in any good fashion. So that's just as a reminder, these are the guidelines where they tell us we should use a pressure of 20 to 25, and just interposing what that means, that there's a lot of time, if you use a pressure of 20 to 25, you can see that a lot of ventilation on each dot is one tidal volume measurement. There's a lot of time you might be over your potential tidal volume you would be tolerating if you would ventilate that baby on the NICU. Now, one approach might be to introduce a respiratory function monitor. Unfortunately, if you look at the latest recommendation, there is insufficient evidence to make those recommendations because the studies out there are just a few and haven't included many babies yet. So they can't really make a recommendation for or against, because it's also because of those low numbers with this low certainty of evidence. Now, what can respiratory function monitors do? Well, I think everybody is familiar with using respiratory function monitor, and everybody is using it in the NICU. And I think it is common that we look at those displays, we look at what the tidal volume delivery is, what the airway pressures is. We discussed the leak, and I'm pretty sure many people discussed the leak on the ward round when the baby's intubated. And we might look at compliance, resistance, we look at volume, pressure loops, and other things when we use it to ventilate a baby in the NICU. However, it seems that it's quite reluctant to make the next step to say, well, I use it when the baby is intubated at 10 minutes of age, for example, but in the first 10 minutes, I just need my T-piece because I know exactly what I'm doing. So I think there's this little disconnect that I don't need it in the first 10 minutes, but I will need it immediately after to help the baby. And I've seen that many times when you try to introduce that, and I can say I tried it in our unit and I failed miserable to try to convince our respiratory therapists to use a respiratory function monitor in the delivery room. And I went so far that one day, just for fun, I went to the NICU and put some black garbage bags on top of the ventilator screens, and the respiratory therapists were all a little bit upset, say, hey, we need them. And said, that's interesting that you need them up here, but you don't need them at birth. And they couldn't really explain why, but they thought, yeah, we know exactly what we're doing down there. So I think there's a slightly disconnect between the first 10 minutes or first hour and then how we continue to care for them. Now, there's a big amount of respiratory function monitors out there. I think there's more and more recognition that this is an important part of neonatal resuscitation. So there's more and more companies who developing different devices. And the first slide here is more like some images of different displays of how this technique is, how the respiratory functions might be displayed. Some might be a bit overwhelming, and I will get to that a little bit later, but they certainly can just display all of these different things. Like if you look at the left top corner, you can see the pressure, the flow, and the tidal volume. And for most of these devices, pressure is always red, flow is green, and the tidal volume is blue. And there's certainly also other devices available, and I just picked up a few of them. You might be familiar with the left bottom one, which is from Monument, or the Resus right on the right bottom. I did a lot of my research with a device called Florian, which is not available anymore, but I use a lot the one on the top right, which is the NM3, to measure respiratory functions. And on the laptop, this is it's not necessarily a respiratory function monitor, it's more like a device to deliver positive pressure ventilation, and that's the next step one. Now, what can a respiratory function monitor do for us? It certainly can help us to improve our positive pressure ventilation by ensuring that we have a good mask position and seal, because I think we often assume we're doing a great job, but then when we're actually measuring it, we figure out, hey, we're not doing as great as a job as we could. We could evaluate positive pressure ventilation, and we can certainly get tidal volume. We get inspiration, expiration time. We can get all the airway pressures. We can get the minute ventilation. We can get the leak. We could assess how the baby is spontaneously breathing and how well a baby is doing at that perspective. And we could confirm if your endotracheal tube is in place in addition or as a replacement of end-tidal CO2. Now, if you look at the respiratory function monitor, and as you saw the screen a few slides ago, several of those respiratory function monitors will have waveforms for you available. And it certainly is the question, is displaying the waveforms like this the best approach, or is there a different way of displaying the information? But I think there's certainly more studies to be done to identify what is the best approach for the clinician to display the information. But this is what many devices do at the moment. And if you go to your ventilators, you will see those similar waveforms. And the only thing really I want to quickly focus on is on a couple of things. So in this, with these waveforms, you will always have a peep of 5 and a peep of 30. Here you can see the flow going in, it returns to 0, and then the flow comes out, which is basically the expiration, and then goes back to 0. And on the bottom, you can see the tidal volume going in, and then you see the concave wave where the tidal volume goes out again. This is an example of a really good ventilation with very low leak to almost 0 leak. So that's what you might want to achieve. And when you do ventilation, you have 2 targets to basically identify if your ventilation is adequate. You assess heart rate and you assess chest rise. Now, back when I was a young PhD student, one of my first studies was to ask people, can you actually assess chest rise? And a lot of people said, yes, that's no problem. When I do ventilation, I'll assess, and I know exactly what I'm doing. And then when we actually asked people who were providing positive pressure ventilation, they were standing at the head of the baby and said, look, is the chest moving? And the answers were appropriate, too low, not at all, not sure. And you can see that even though a lot of people thought either the chest was moving appropriate, or on the other hand, too low or not at all, they were actually either in the right way and the right range of 4 to 8 mils, which we defined back then as the right. And the people who thought they were having appropriate chest rise had even too much chest rise, or you might have considered, oh, there was too much, so maybe seeing hardly any chest rise or no chest rise at all might have been the best for these infants, and they were all premature infants, less than 32 weeks gestation. Now, many of them were in a plastic bag because of thermal regulation, so that certainly is also something which might hinder your view to assess this correctly. When I presented the data, there was a lot of established neonatologists came up and said, well, you're young, you haven't learned how to do that yet, but I'm established, I've done that for more than 20 years. I can certainly assess chest rise, so you will learn it too. So we went back, and that was all back when I was at the Women's in Melbourne, and basically tried to do that. And so we had people standing at the head, which were junior trainees, were either residents or fellows, and we had the senior staff neonatologists standing at the side of the bed and asking the same question as before. At the same time, one had to write it down and one had to say it out loud, and both were as good or as bad. So it doesn't really matter in the end if you are experienced or not. It's challenging to assess lung aeration by looking, or it's challenging to assess chest rise to see if you're adequately ventilating. Now, for a short period of time, I think in the guidelines it was less prominent, but certainly in the last few years, looking at chest rise has been more prominent in the guidelines again. So it seems like it's more reactivated again to emphasize chest rise again. And I think one of the problem was when you look at the TAL volume delivered, when we ask healthcare professionals when they were mask ventilating, that the TAL volume was quite variable and could be low, could be high, could be extremely high. So that it's quite challenging. And you see the red dot that's what people thought they were delivering. So it's quite challenging by just looking at chest rise to know if you're doing the right thing. Now, when you do mask ventilation and you can use a respiratory function monitor, you certainly have some advantages for compared to not using it, because there's certain pitfalls of mask ventilation you might want to be aware of. First of all, our masks are not always the best fitting masks, and we've quite limited supply of face masks available. There's only a few major companies who provide face masks, and they're not always fitting all of our premature babies. Now, there's many studies out who showed us that mask leak is quite common, and it doesn't matter how well you're trained. You could be newly trained or someone working for 10 or 20 years. Your mask leak will vary depending on the infant and depending on the day. So it might be that you have one day great mask ventilation and the next day you're doing not so great. So it's irrespective of training. You have a lot of leak doing mask ventilation, and a lot of time it's quite large. It often occurs more likely at the beginning of positive pressure ventilation, and it reduces your delivered TAL volume, which on one hand might delay gas exchange and delays lung aeration, but it might be on the other hand not so bad, because you might otherwise, if you have no leak, deliver to high tidal volumes. So maybe leak protects the infant's lungs to a certain degree from the heavy hand of the provider of mask ventilation. Now, this is just, if you look at any of these respiratory function monitor screens, you might see the waveforms like this, and the left top corner is the one I showed you previously, which is an optimal mask ventilation. And on the right top corner, you can see again the pressure from 5 and 30. But if you look at the gas flow, you can see that the area underneath the curve on the gas flow is, for the air going into the lung, is much larger compared to the area under the curve coming out of the lung. And that's also then representative in the tiled volume on the bottom, where you can see the air going in. The concave comes out is quite short, and then it's abruptly ends, and it's resetting because the next inflation is starting, and then it repeats again and again. Now, the only thing I really want to point out, because I think a lot of people will recognize that there is a leak, but the problem is that if you look at the first leak with the error, the second and the third, you can see that those, you can pretty sure appreciate the straight lines are all different height. It's still 80% leak in each of them. And so I think it might be quite challenging for everyone to use waveforms to identify how bad the leak is, or how bad your ventilation is, that there may be a numerical display, might be something which is better for everyone to identify it and then help the baby or reposition the mask. I think the second thing which a lot of people don't believe often is that there is 80% leak and you still reach your pressure. So just looking at the manometer to see if there is leak and to see if you still reach your PIP of 30 in that case might also be deceiving, because at 80% leak, you can still reach your 30 PIP, which was set for this resuscitation. Only if you get above 80 or so, 90 or 100%, you might see that you don't reach the pressure, like in this scenario here at the bottom, where you can see that the pressure is quite variable, because even though it was a T-piece, you can't reach it. There's hardly any flow coming out, and the tiled volume is quite non-existent. And once they reposition the mask, you can see that suddenly it's a beautiful mask ventilation. Now, there have been 3 trials so far where they used the respiratory function monitoring doing mask ventilation to see if that reduces the leak. This is one of them, which showed that yes, your mask leak can be reduced. And in the end, if you look at all 3 trials which are out there, you can see that in 2 of them, mask leak were significantly reduced when the display of a respiratory function monitor was visible, and the largest one so far to date was unable to find a difference in that area. But in general, I think it might help you to reduce mask leak, but there's only 2 of the 3 trials who identified that as a significant difference. Now, one thing which hasn't been really studied, and it's often overlooked, is what is the best approach to hold the mask. So when you have to provide mask ventilation to your to the newborn infant, and what comes out from a simulation study many years ago is that the left image with the 2-point top hold would be the best. Having said that, I think no one has ever actually looked, if you now try this on a few babies, if that actually is true, or if there's maybe a different approach which might help you to reduce the leak even further. Now, interestingly, even though we only have those 2 face masks available, and they are not often not fitting as well, there's a couple of studies who compared using a Fisher and Paykel with a lateral mask, or this lateral again with a smaller mask, a Fisher and Paykel one, and what they found is that it doesn't really matter from the leak perspective, that it will remain the same mask leak. So the mask leak is quite similar regardless of masks you're using, which is quite interesting. Certainly, what particularly the second study showed is that if you get less than 26 weeks and you use the masks, your leak seems to be much larger, just because the mask is in less fitting. Now, if you introduce a respiratory function monitor, you might want to consider introducing it already for training, because this nice, rather large study of over 200 people enrolled found that if you use a respiratory function monitoring during training, you certainly will be able to reduce leak at the end of your training session, which is, I think, what amazing, because how you normally judge when you do neonatal resuscitation training that the person is providing mask ventilation. You just look at the mannequin, see if the chest is rising, and see if they're having a good mask hold, but you've never measured it objectively. And a respiratory function monitor will help you to objectively measure if the if that mannequin is ventilated correctly. So it certainly is helping. What hasn't been done and would be a nice addition is to see if you do that during training, does this translate into better mask ventilation in the delivery room? One thing which has been talked about it for a while, but I think that maybe it was just a wrong observation a while ago, is airway obstruction. We often talk about that if the head isn't positioned in the right way, that you might get airway obstruction. Others report that if you slam the face mask too hard onto the face, you might get airway obstruction. Studies have reported that you can have quite a high number of airway obstructions. Other studies who used a PDCAP, which is a colorimetric CO2 device, mentioned that particularly early on, there was airway obstruction because there was no color change from purple to yellow. Now, knowing that it might take a minute or two to get gas exchange, they might have just observed that there was no gas exchange yet, and not really airway obstruction, but as there was no respiratory functions or anything else measured, we might not know. But that certainly could be one of the things they have monitored or measured back then. And if you look at the latest respiratory function monitor RCT, interestingly, they found 0 inflations with airway obstructions, while other studies prior to that found many inflations with airway obstructions. So maybe airway obstruction is something that people thought they saw, but given what we know nowadays, it might not be really airway obstruction. It might be something which has been circulating around now a few years, but I think it's coming more into our mind, is that it's actually not that the airways are obstructed, it's that the vocal cord, so your glottis, is closing, which it does also in utero, but once the baby is born and it's still in this hypoxic state, that it might closes the glottis. And just imagine when you try to give positive pressure ventilation and the door is shut because the vocal cords are shut, then you're not really able to deliver any inflations, and you can only deliver that once the glottis is opening. And there's some work by the group around Stuart Hooper where they actually showed in those rapid pups that only if the glottis is open you can get lung aeration, and the glottis in these rapid PEPs only remains open once there's really good aeration and ventilation established. So that's certainly something we should keep in mind, that when you struggle to ventilate, you might have a closed glottis, which hinders you to provide mask ventilation. I think one of the solutions might be, but there's certainly more research to be done, is to provide some stimulation that might can help you to open up those glottises. And this is just, again, some earlier work to highlight that you might get some glottis closure doing positive pressure ventilation, where you can see that if you look at these graphs, particularly at the pressure, you can see that at the beginning there's a pressure remains high for several seconds, and that's a sustained inflation they were doing at that time. But you can see nice little dips, which are spontaneously with a breath, where the infant is spontaneously breathing in between, suggesting that the glottis is open. And then if you compare those pictures with these ones, you can appreciate that here is no air movement because the gas flow is zero. So that this reflects a closure of the glottis and not necessarily airway obstruction. Something in addition, we might have not really paid attention, and is a reason why we might need mask ventilation more often than we should provide it, is the trigeminal cardiac reflex, which is activated every time you place a face mask onto a infant's face. Is a reflex which causes bradycardia, could cause a systole, can cause apnea, and you might have observed that when the baby is born, gets delayed cord clamping, is crying beautifully, you clamp the cord, the baby's potentially is continuing to cry and breathe, and then you place a face mask onto the face, and suddenly the baby is apneic, and you have to start providing mask ventilation. Now, this could be just because of the cord clamping, and as the cord clamping was long enough, and there's some changes in the cardiovascular circulation, which causes them to get bradycardic or apneic. But it could also be that you activated the trigeminal cardiac reflex. Now, does that happen, and how often does it happen? Well, there's a few studies out who looked at that, and one was reporting that's around 11% of infants, greater 34 weeks where that happens. Others who looked at smaller babies and found that up to 86% were breathing before you put the mask on. 50% of them stopped breathing for up to 20 seconds, stopped breathing a few seconds after, and then I had up to 30 seconds where they're not breathing. So yes, it happens, and it might happen more often than you think. And it's maybe something we should always keep in mind, that it might not be that the baby is more sick. It's maybe something we initiated because we activated that reflex. Now, what would be a solution? Well, face masks are the thing we most commonly use, particularly for extreme premature babies. An alternative might be nasal prongs for these extreme premature babies. If you're an older baby, I think there's more and more evidence coming out that a laryngeal mask might be the alternative if you are over 33, 34 weeks or over 1,500 grams for sure. That should be more likely used compared to a face mask. But certainly if you go lower down the gestation age, there's no laryngeal masks as an alternative available at the moment. So we either stick with face masks or nasal prongs. Now, there is a meta-analysis from all the randomized trials available who compared face masks with nasal prongs. Now, they didn't look in detail in does this reduce mask ventilation in the delivery room? Does it reduce apnea or bradycardia due to placing a mask or so? But which is unfortunate because we can't really then make any conclusions about if that might reduce these events. But certainly it doesn't change anything in. It certainly doesn't change anything in regard of your major outcomes to either use a face mask or a nasal prong. Now, the last part is I want to briefly chat about the delivered tidal volume we give during positive pressure ventilation. Now, what we do is we're going to assess how we do by looking at heart rate and chest wall movements. We're not measuring the tidal volume routinely. We use a set PIP, with which we then assume it will deliver this appropriate tidal volume. But remember, your PIP will always depend on your lung compliance, which varies with gestation age, whatever disease the infant has, your delivery mode, and how much your lung has been aerated. And if you just use the fixed PIP and then assess heart rate and chest wall movements, you might get over or under ventilation, if you remember the graph with the tidal volume delivered depending on the pressures I showed earlier. And it's just to re-emphasize that again, that when any ventilation, you will have any person who ever does positive pressure ventilation and thinks about how much they deliver, they might be spot on, but they might be also quite wrong, and you will see that your tidal volume will be quite variable when you deliver positive pressure ventilation. Now, if you use a respiratory function monitor, there's certainly ways of targeting how much tidal volume you are giving in this. In this case, there was no respiratory function monitor available, or it was blinded to the team. You can see that they started with a pressure of 30 with a quite low tidal volume, then they increased the pressure. And I think a lot of people might say, oh, 5 to 8 mils per kilo might be a good tidal volume they were delivering, but then they went just further up to a higher tidal volume because they weren't monitoring the tidal volume, and then they were delivering a quite large tidal volume. So certainly something which you can only recognize if you get a respiratory function monitor. And that's just an example how this technology might be used, where you can see a pressure of 30 again, a low tidal volume, increasing the volume, increasing the pressures, increases the volume to 10, and then decreases the pressure to 20, and then delivering a tidal volume of around 5 mils per kilo. Now, just keep in mind, it's not that it was only a few seconds, as you can see here in the graph. These graphs are cropped together to make the point. So certainly the team would have been using that pressure for at least 30 seconds or longer, and then we're changing it. Now, half the studies who used respiratory function monitor and randomized the infant either to be blinded to the screen so that the healthcare providers didn't know what they were doing versus they knew what they were doing. So does that reduce the tidal volume delivered? Yes, it does reduce the tidal volume delivered. It might not always be significant, but if you look at the box, you can see that the delivered tidal volume was certainly lower when the respiratory function monitor was visible. Now, if you look particularly at the bottom of this systematic review we did a while ago, you can see that overall the diamond shows that you certainly are able to reduce high tidal volume delivery, so that there's more likely that your tidal volume is less than 8 mils per kilo, which has previously been basically suggested as a safe range and not above of the 8 mils. So it certainly might be helpful. Sorry, direction. Now, a while ago, I was just asking the Twitter, and you can see it was like a bit more than a year ago, asked the Twitter community, what would they like to target in the delivery room? And I would just ask a very simple question: should it be 4 to 8, 4 to 6, less than 8? A tidal volume target is not important, and the majority would use 4 to 6 mils per kilo, which I guess is something many might also do in the NICU. So a lot of people would target less than 6 mils or 4 to 6 mils per kilo. Now, if you use this technology, and this with every new technology, there's some concerns about adding new technology into your delivery resuscitation, because it certainly can affect how you do your resuscitation. And if you look at this, one of the studies we did with some with a few babies where the staff had to wear eye tracking glasses. And what we found is that only in 35% of the time, the people were looking at the infant, and the rest, they were just looking at the other healthcare professionals' devices and other things. So the focus is maybe not as much on the infant as we were hoping to see in that study. And this study was using basically from randomized controlled trials where they had the RF visible mask. And what is quite striking is what you can see is that when the RFM was masked, up to 50% of the time, the team was looking at the baby. But when there was an RFM visible, a lot of the time got then diverted to the RFM monitor, which might be a good thing, but it also, if it distracts you much more from looking at the infant, and you might have maybe more mask leak, or you continue to ventilate if the baby isn't really needing ventilation. That certainly could be concerning. What none of these studies has done so far is looking at the mental load or the extra workload people have if another device is added to the NICU. The last thing I want to share is just some thoughts and maybe why another reason why a respiratory function monitor might be important. Now, we've done this systematic review where we looked at all three trials who comparing respiratory function monitoring, and what we found is that certainly given the limited numbers of babies enrolled in, and you can see it's like less than 500. None of these studies found a difference in death before discharge, either if the respiratory function monitor was visible or masked. It also didn't really make a difference in chronic lung disease, because there was this idea that if you reduce your tidal volume, so and a few slides ago, the forest plot showed that it was significantly less time, significantly lower, that you get tidal volume above 8. So that should result in a reduction in chronic lung disease, but that did not happen, again, with this limited number of babies so far. Even though the diamond moves in the right direction, it's just either not enough infants recruited, or it might not occur at all. But what's something which was striking in this analysis is, and that's but not something to take away and say, oh, this might be the best approach for helping with brain injury. But what we found is that brain injury, and that was defined as severe IVH, brain injury was defined as IVH, severe IVH and PVL was reduced, significantly reduced, which bears for the fact that if you start delivering high tidal volume, and that comes from sheep studies from Pogles and others down in Monash, that you start an inflammatory cascade in the lung, which then travels into the brain, with the inflammatory markers travel to the brain and cause leakage in the blood-brain barrier and causes lung injury, causes brain injury. So maybe a respiratory function monitor might be not your best tool to reduce chronic lung disease, but it might help you to reduce brain injury, which I think is also a very important part of our daily care. So maybe that's a more likely scenario that this will help in that regard. But it was only secondary outcome in any of these trials, so it might not be a result of using the lower tidal volume. So that certainly needs further studies to examine it. So in summary, mask ventilation is often challenging. You might get a leak, and it is common. It could be airway obstruction, but as I hopefully showed you, it might be also glottis closure and not really airway obstruction. as we have defined it. You can use a respiratory function monitor to identify leak, obstruction, or glottis closure. You can identify, you can use it for tidal volume delivery. It might not reduce BPD, but maybe has a place in reducing brain injury. And with that, I would like to say thanks for your attention, and thanks to anyone on the team I've worked with over the last 10 years, and happy to answer any questions.
Thank you, George. Brilliant presentation. And you would not be surprised that there are lots of questions. Hometown advantage, we'll give it to Mark first. Mark, your question is quite easy, but chime in if you want to say something else. Quite simple, sorry, compared to Kurt, who's next up. So, George, can you comment on the use of nasal prongs with RPEP to avoid apnea?
Yes. Well, I've seen several studies, and I think Snorri Donaldson has done a great work to basically study that in a lot of details. And the meta-analysis didn't really have the large study of him in that much details. And I think I don't think it's the nasal prong per se, which is the great thing about the RPEP. I think it's how the system works, because a lot of people use a T-piece, and the T-piece you're exhaling against a high resistance. And I never paid too much attention about using the T-piece or not using the T-piece for CPAP. But the moment I moved to Edmonton, and it was quite, all our T said, now we don't want to use the T-piece. We use the viases. So we're going to do PPV for a minute or two or 3 minutes. When the baby stabilizes at 5 to 6 minutes, we slam the viases on, because we don't like the T-piece because it has too much resistance, and the baby is struggling to breathe against the T-piece. So I don't think it's the nasal prong, but I think it's just the design of that T-piece that improves how the babies can breathe.
Hey, thank you. And Kurt, do you want to, are you still there, Kurt? You always ask very long questions. Yeah.
This is not hard. Thanks, George. This is a great overview, particularly of those respiratory function monitors, which I personally don't have much experience with, but read a lot about what it can do. You explained that it is difficult to actually find, okay, now we know tidal volumes or obstructions, but what is optimal and what is best? And what is the outcome we're actually trying to create? I was fascinated by that outcome on brain injury. One of the things you mentioned, and I think that's a highlight, is heart rate. And the heart rate, and picking up heart rate, particularly in the first 2 minutes in the techniques we use now, is pretty poor. And we now have ultrasound machines, they're portable, they're relatively affordable. And is it the time that we sort of, start using them in the first 2 minutes to assess heart rate and even cardiac output or stroke volume? What do you think?
Yeah. Well, I think, for heart rate, you're right. I think the technologies we use, they're quite cool. Like pulse oximetry, it only might take 90 seconds that you get a reading of heart rate. So it takes a while. If you auscultate or if you palpate, your studies have shown that you could be off by 20 to 30 beats per minute. So you might do too much or not enough with interventions. ECG also takes some time. So I think, yes, we should use newer technologies. And there's one from Leerdal, which is just a clamp to measure heart rate, which gives you that instantly within 3 seconds, but they don't, it's not available unless you're in a developing or low resource setting. So that's quite unfortunate. Ultrasound, I think it's a great tool to use, but it's similar than auscultation or palpation. It's just once in a moment. So you might not have enough people just to have it on there continuously. So I think it's great to do a quick assessment to see where you're at. You can get the stroke volume and other things as well. That's certainly something which might be interesting, but it might also complicate things to get it in. We try to do some echoes when just to measure some of the cardiac function, and a lot of people are not happy. With you fiddling around with some extra tools, they're trying to do mask ventilation. So it might be something for the future, and there's several studies out who showed you can measure it, so it's quite accurate. We've done studies with cardiac output devices, and the thing we found is that even if you do PPV, it measures cardiac output, but it doesn't. It's not. But those peaks were like asphyxiated. So and they were asphyxiated on the systolic, and we still measured heart rate with cardiac output. So there's some of these devices which I would caution for. And there might be newer things, that we move more and more into technology, things like, there's video cameras available where you can measure heart rate. Yeah, so maybe, using this technology in the future where it's, touchless, where you just have a camera and it gives you the heart rate, might be the optimal solution, because you can have it attached to the cord, you can measure it, that's the next thing. People might want to measure it attached to the cord if this is the way we're going, and then you can't do the ultrasound easy because it has to be sterile. But ultrasound is certainly something, if you have it available and you need a quick assessment, use it.
Thank you.
Thanks, Josh. Okay, last two questions. Quick one from Sunil. Can you comment if the tidal volumes are improved if you use laryngeal masks, if you give IPPB face masks?
Good question. That there's actually a lot of people used laryngeal mask for studies, but there's not really data out on respiratory function monitor. So there's only one small subset of patients have been published, and I think the tidal volumes, as far as I remember, they're quite similar. So it's not that the tidal volumes are necessarily improved. I think it's just what the studies found is that you need shorter period of time to provide positive pressure ventilation, which is a good thing. And it's less likely that the babies needed to be intubated and then, had more NICU treatment. So, but the tidal volume hasn't been really measured. Most of the studies, they're quite pragmatic. They just compare mask ventilation with laryngeal mask and not try to be too fancy and add respiratory function monitoring, which is quite challenging to do it in a large scale study. So it's not much evidence out there, to be fair, unfortunately.
Mark has his hand up very patiently. Shall we go to Mark first and then Martin? And then Mani.
Very quickly, fantastic talk. I just want to expand and ask on the concept of what information to provide, and in a way that does not distract from the core purpose of the resuscitation, which is to keep on view the baby. A lot of the tech that we've all been using is very complicated, and the NM3 you can no longer buy, and as the fluorine monitor. And so shrinking everything down, make it on view in line of sight of the baby, we would think is the best way to go. Do you think we study these babies long enough to see an impact of appropriate tidal volumes? Maybe the RCTs at a limited volume numbers are simply not seeing enough minutes of ventilation to show the desired benefit in chronic lung disease.
Yeah, for your first part, I think it hasn't been really studied, and we like what information you need, how much information is too much, and we tried that. What we did is we had only pulse oximetry and heart rate available, and then we added an RFM, and we wanted to add NIRS afterwards, but it was quite challenging to get this done because you need to get the same people doing the same study, like the same stuff. And it was really challenging to do that in the delivery room. Sorry. So we got in the we're just analyzing the data, and I think we might be ready to present it next year. So we managed to get an RFM in, and we're just analyzing it. So I haven't seen the results yet, but it's certainly something which hasn't been really paid attention. What information is right? How to present the information? A lot of companies just put out devices and use it, but no one ever does an assessment. What of that information you want to hear or see, and how to present it, and where. Like, we've done studies with monitor placement, if you want it in the middle or on the side, and that doesn't really make a difference. So I know that won't happen everywhere because it's just a numbers game. But if you look into the adult world, they have a person who runs the code and who will look at all the monitors and gives the commands, the orders, and guide and runs it. Maybe if you work in a certain size unit, this is the way to go. Certainly that won't happen anywhere, because I know how it is. If you're level 1 or level 2, you have 1 or 2 people. That it's never will happening that way. But I think where we look after extreme premature babies, that might be the way to go. And for your second part, did they maybe not have enough positive pressure ventilation? Potentially. But, I think the problem is that we don't do what adults do, 20, 30 minutes of ventilation or more when you have any of these events. And it's the same with like if you do CPR, adults do CPR for an hour or longer before they would call it quit. We do 10 minutes or 20 minutes and then we call it quit. So certainly I think they might have not had enough ventilation time to find a difference. But also, if you do a trial of 1,000 patients, you might find a difference, because 200 isn't really a large trial, it's not that will give you all the information you want.
Thank you. So we'll go to the last 2 questions. Maybe we have a quick one from Mani first, and go on to Martin as the last question, because he's got a more involved one. So Mani's asking about the different shapes of the face mask, round versus oval. Do you have any opinion for that, for leak?
Believe it or not, there's only one small mannequin study who examined if anatomical shaped or round mask makes a difference. And in that small mannequin study, it did not make a difference. I know that Europeans, I think it's more common to use an anatomical shaped mask. We in North America, and what I know is we basically just use the round mask, and I think Australia might be similar. I don't know. I think they should both work, as long as they're designed in a way where it covers your mouth and nose, it seals it off. I think they would work similar but yeah, there's not much studies out there, to be honest.
Thank you. And very last and best, Martin, you have a very long question. Can you ask it yourself?
It's not that long, Julie. Thanks. It won't take too much
Oh,
time.
come
Thanks,
on.
George,
There's a lot of...
Thanks for a great talk, George, as always. Just 2 quick questions. One is regarding the use of respiratory function monitoring to teach people to reduce mask leak. Is there a risk that in the teaching they'll focus on the monitor and the RFM and they'll be missing some of those real life cues, and then when they translate that into real life, they haven't really been focusing on those, and it will actually mean that they are less competent to reduce leak? And I'm talking about these new simpler respiratory function monitors that are actually being used in teaching programs rather than necessarily data collecting RFMs.
Good one. That's a good question. I know, as I said, they did that in the simulation study and showed that it reduces mask leak when you assess it, but no one has really done the next step to examine that in the delivery room. And I think it could happen that they might be less aware, particularly if you don't use a respiratory function monitor. And there's not really any data out there. I think the one thing, and I don't think it's a great comparison, but it's a potential comparison. Like when we started using video laryngoscopes, people were afraid that if you use a video laryngoscope and then you go back to use a normal laryngoscope, that you might be unable to intubate. but the studies have shown that if you use a video laryngoscope during training, and then you have to convert back to a normal one because you don't have one available, you still be able to successfully intubate. So I'm not saying it might be the same with a respiratory function monitor, but there's two different technologies used, and it worked. So maybe it's the same, but really, I don't know.
Thanks. Julia,
Mark,
we're
any
over. I'm
comments?
happy for the second part of the question just to be left there for this as a question. George can answer it later. So.
Okay.
Can I just
Okay.
make a quick
I think
comment
Mark
that,
wants to say something. Yes.
Well,
Last one.
I think the elephant in the simulation lab is that we've looked at 17 mannequins across Westmead campus, Children's and us, and more than half are not fit for purpose. They've been damaged, they've got internal leaks. We are training people in very often circumstances where the mannequins are not reflecting even what a new mannequin would do, let alone what would happen in a real baby. And I think the RFMs of any sort can help in training with mannequins, just simply to identify that you've got an adequate technique, but also that your mannequin is fit for teaching purposes.
Very interesting.
Yes, interesting. Very interesting, yes.
Okay. So thank you very much, Georg, and for the great discussion, everyone. Rahul's put up the QR code, so zap it if you want to record your attendance. Otherwise, we have you on record anyway, so the college can always ask for proof from us. All right, so have a great time in India, George. All right,
Thanks.
stay safe,
Thanks.
and see you soon in PAS. Thanks, everyone.
Yes, see you soon, everyone.
Thank
Bye-bye.
you, George.
Bye.
Thanks.
Bye.
Nice to meet everyone. Bye.
Recording stop.